Thank you very much for inviting me to this meeting. I'm not an economist and cannot provide you with a comprehensive analysis of the cost of nuclear medicine, but I will show you some cost definitions and their limitations and provide a recent example illustrating that cost assessments overall and in nuclear medicine in particular require a far-reaching assessment, almost, I would say, to the scale of national and world economies. I am, of course, working in the US healthcare system, which is very different from almost any other systems in the world. My comments are therefore limited as they don't address other healthcare systems. But first, my disclosure statements. None of the data that I show here are related to these interests. So I want to start out with a few definitions to clarify the terms we're using, as cost has multiple and often ambiguous meanings. It means different things for providers, payers, and patients. For providers, such as hospitals, cost means expense incurred to deliver healthcare services. To payers or insurances, cost means the amount of money they pay to providers. And to patients, cost means out-of-pocket payments for healthcare services. Charge or price is, in essence, what providers charge for a health service. Yet charges are very different from reimbursement, which is the actual payment made by insurance to a provider. This is usually in the US a fraction of the charges. And finally, there is the term of cost effectiveness, which connects cost with outcomes, whereby effectiveness of an intervention is compared to an alternative or alternate strategy. And the outcome is, for instance, defined as quality adjusted life years saved. This is the most meaningful term in my view, as it now includes patient outcomes, and that's what it should be about. And it has even further reaching implications on a kind of a societal and global level. I want to start the discussion with a well-known example of nuclear medicine, precision medicine, and that is the theranostic pair to image and target or treat therapeutically the prostate-specific membrane antigen, or PSMA. This theranostic pair has gained enormous visibility, and I will use it as an example of oversimplified cost considerations. Imaging of PSMA expression is now FDA approved in the United States. It's Medicare reimbursed, which is the insurance for everyone older than 65 years. And it has become part of the prostate cancer guidelines from the National Comprehensive Cancer Network. There are many other targets that are being explored or already exploited clinically, as shown in the box below. And they will be discussed a little bit later. But theranostic targeting of the PSMA receptor is changing the way prostate cancer patients are managed. This is a very simplified diagram that illustrates the concept. You have a target, you have a ligand that can be labeled with a diagnostic or a therapeutic isotope, and you then obtain first images to see the target. And then if the target is expressed, as shown here, then you treat the target with, for instance, 177 lutetium PSMA. And then after treatment, you see all these black spots disappear. The treatment was successful. The question is, of course, how much does the imaging cost? How much does the therapy cost? And is the combination of these two really a fair assessment of overall healthcare impact? Here are three examples of molecular radiotherapies in theranostics. The examples include dotatate for imaging somatostatin receptors, PSMA, as discussed a second ago, and then 223 radium to look at to treat bone metabolism. Let's take PSMA as an example and let's assume an expensive scenario. For instance, the US scenario. A PSMA PET CT scan may cost $5,000, and each lutetium PSMA treatment cycle may cost $50,000, that is. Let's assume that each patient undergoes 3 cycles. This would cost the system around $150,000. If we assume that 40,000 patients a year would undergo this treatment, the total cost would be $6 billion per year. If we use PSMA imaging to determine whether the patient is a suitable treatment candidate, in other words, whether the target is expressed, and we assume a very high cost of $5,000 per scan, we add $200 million to the cost. However, if we, based on imaging, exclude 20% of the patients from treatment because target expression is low or heterogeneous, we save the treatment costs for 8,000 patients, that's 20% of 40,000, or we save $1.2 billion. Thus, the investment in imaging, nuclear medicine imaging, would have saved a net of $1 billion. However, healthcare cost assessment and nuclear medicine cost specifically are much more complex than even this. Matters are more complicated as terms such as cost and effectiveness and reimbursement levels are frequently mixed up and used very liberally. Here we have not analyzed cost and outcomes of alternative treatment strategy, as is done, for instance, in sophisticated decision tree sensitivity analysis. Assume, for instance, that a second taxane treatment would have been given instead of lutetium PSMA, and it would have been effective or not effective, but would have been less expensive, and it would create side effects that may or may not be as expensive or be more expensive than those from molecular radiotherapy. The financial impact of outcomes, side effects, complications, or simply wrong decisions leading to poor or better patient's outcome are not considered here. And even this does not address real cost for society, as improved productivity following a successful treatment may have a much larger economic impact than itemized imaging or therapy costs. In the following, I want to emphasize that issues are more complex, and single examples of adding one new imaging tool may increase healthcare expenditures, but may at the same time lead to enormous cost recovery in other sectors. First, some numbers and facts that underscore the enormity of healthcare and its financial impact. The worldwide discussion of healthcare costs has its roots in societal burden of prioritizing scarce financial resources, in prioritizing and allocating them. What is the value of one quality life saved? Is this value the same for each age group? Who decides the value? These are important ethical and economic questions. The US spends $3.8 billion on healthcare in 2018, which accounted for 24% of total government spending. At the same time, healthcare as a business generated around $1.8 trillion in revenue. Healthcare is the number one employer of 14% of the US workforce. And one should not forget there's also considerable tax revenue from payroll and income to corporate tax. I do not know how these revenues are accounted for in the concept of healthcare expenditures. Whether these monies are well invested is a different question. It should be judged on a patient level by improved quality of life and improved progression-free survival and overall survival in cancer. Moreover, there's little known about the downstream economic effect of improved progression-free and overall survival, such as improved lifetime productivity, which we will get to in a moment. So where do the 3.8 trillion healthcare dollars come from? The panel on the left shows the sources for covering expenses. 73% come from health insurance and 11% from out-of-pocket payments. Again, these are numbers from the United States. But they indicate that patients come up with close to $400 billion to cover healthcare expenditures out of pocket. Of the health insurance contributions, private insurance contributes 31%, while Medicare, Medicaid, and other government programs account for 70%. Panel on the right shows where the money goes. 30% is used for hospital care, 20% for physician services, and 10% for prescription drugs. I would like to mention that administrative costs in the US system are much higher than in any other country. But what about imaging and PET imaging, nuclear medicine imaging in particular? And we looked at this about 10 years ago when we analyzed the Medicare cancer expenditures incurred by PET imaging. At this time, FDG was pretty much the only and lonely player. Thus, the absolute dollar amounts shown here underrepresented as they were based on more than 10-year-old data. However, the relative contributions are probably largely unchanged. In this analysis, non-imaging expenses accounted for 95%, imaging to less than 5%, In nuclear medicine imaging, in this case, only PET for only 1% of Medicare cancer expenses. This is really only a small fraction of the overall costs. Now the landscape is changing now. This was the old nuclear medicine world. Now nuclear medicine is booming. Company revenues are growing quickly. Providers and patients will have to pay more for these services. Diagnostics will grow most dramatically, but growth is expected in all sectors, including conventional nuclear medicine. The nuclear medicine market will grow to more than $13 billion in 2025, and depending on target discovery and the development of theranostic pairs and imaging biomarkers, this will keep growing at a very fast pace. We now have established and emerging diagnostic and therapeutic approaches. I've outlined them here, but will not go into detail. Some have already generated considerably of the new ones industry excitement, such as inhibitors of fibroblast activation protein, neurotensin, or carbonic anhydrase 9 for renal cancer imaging and therapy. But again, are these just adding costs? How expensive are they? And what is their potential societal benefit? Here, a quick look at the worldwide cancer mortality trends between high versus low and middle income countries. Cancer incidence is decreasing in high income countries, but increasing in low and middle income countries. And the reasons are clear. In high income countries, you have screening, diagnosis, better therapy, smoking cessation programs, vaccinations that, for instance, reduce cervical cancer and head and neck cancers, as is the case for HPV vaccination. In the low-income countries, you have limited screening, no smoking cessation programs, infections, constraints related to diagnosis, which is imaging and treatment. And in fact, the highest incidence of cancers worldwide, cancers of the stomach, liver, esophagus, and cervix, are now coming from low and middle income countries. And here's some more data taken from a recent publication in Lancet Oncology, led by investigators from Harvard, Sloan Kettering, and the International Atomic Energy Agency, in which the impact of treatment and imaging modality availability on 5-year cancer survival was estimated. The table shows stage distribution and 5-year survival for 11 selected cancers stratified by income levels. And these data are really sobering. For instance, stage 1 cancers have worldwide an overall 5-year net survival of 77%. However, in low-income countries, the survival is only 8.4%. And if you go to stage 4 cancers, worldwide survival is 25%. And in low-income countries, it's only 2.5%. So these data tell you that there's an incredible disparity. And the authors concluded that even after accounting for stage of diagnosis, we find large differences in survival by income group, with 5-year net survival an average of 12 times higher in high income than in low income countries. How can this dramatic disparity be addressed? In the same paper, the authors modeled the impact of introducing quality of care standards, all treatment modalities, and advanced imaging modalities on 5-year survival in countries with varying income levels. Shown here is the example of 5-year survival of cervical cancers with cumulative scale-up of treatment and imaging. The 4 lines represent the countries with different income levels. Improving the quality of care and introducing therapy options has the greatest impact on survival. However, imaging, including ultrasound, X-ray, CT, MRI, PET, and SPECT, also had a significant impact on 5-year survival from low to upper middle income countries. In a recent leadership discussion for the Journal of Nuclear Medicine, I asked Mike Sateke, who's the leading African molecular imaging Theranostics expert, whether nuclear medicine techniques could be considered luxury items when developing healthcare systems in Africa. He responded forcefully by saying, "It is wrong to say we don't need CT and other techniques. It's the wrong message." What he meant was, that we would simply give politicians an easy excuse and way out for not aiming for excellence in healthcare in developing countries. Back to the cost of nuclear medicine and overall imaging, and in fact going beyond cost in its traditional assessment. A subsequent paper in Lancet Oncology, authored by many of the same authors, modeled and analyzed the impact of high-level imaging on cost and survival in countries of various income levels. Data are shown here. Scale up of imaging could reduce cancer deaths by 3.2%, which sounds low, but this means 2.5 million cancer deaths between 2020 and 2030. This would add $6.8 billion in costs, but results in lifetime productivity gains of $1.2 trillion. In other words, for every dollar invested in scaling up imaging, the net return can be as much as $179. If one scales up quality of care, imaging, and therapy, so all of the three pillars of potential improvements, 12.5% or 9.6 million of cancer deaths could be avoided, and the return on investment could be as much as $12 for every dollar spent. So costs versus healthcare and economic benefits of scaling up diagnostic imaging for cancer, in my view, represents a very strong case for investment. I want to summarize and conclude here. Itemizing individual procedure health therapy costs provide limited insights into the economic impact of health systems. Healthcare is a complex system that cannot be analyzed by simply adding or subtracting itemized expenses for individual procedures. A holistic view is needed. Scaling up medical imaging and access to nuclear medicine can induce substantial health benefits for patients. Imaging alone results in markedly improved healthcare outcomes in developing and developed countries. Scaling up quality of care, diagnostics, and therapeutics in developing and developed countries may be the best investment socially and economically, as lifetime productivity will increase substantially. Thank you very much for your attention.